Good evening, everyone. A very warm welcome to all of you to Oncology Classroom evening session. This month, we are discussing different interesting topics from pediatric malignancies. And as part of that, today evening, we are going to have a very interesting discussion on the role of proton beam therapy in pediatric malignancies. This talk will be given by Dr. Srinivas Chilukuri. Dr. Srinivas is a senior consultant radiation oncologist currently working at Apollo Proton Cancer Center, and he is mainly taking care of pediatric oncology other than sarcomas, lymphomas. Dr. Chilukuri has his keen interest in pediatric malignancies and is trained from prestigious Tata Memorial Hospital, Mumbai. Thank you, Dr. Srinivas, for accepting this invitation. And without wasting any further time, may I now request you to please take over the session and start your lecture. Thank you so much for being with us.
Some people believe in it, some people don't, some people not yet. But when it comes to pediatric malignancies, they're not very common, by the way, but if it comes to pediatric malignancies, proton therapy is definitely the most preferred modality of treatment. And there is very little doubt in a lot of people's minds regarding proton therapy as an indication for this group of patients. And I'm proud and I feel very happy that I'm able to use this modality for children, where the benefit of this modality can be extended to the maximum extent. So this is our center, which is in Chennai. It is a nearly 150-bedded hospital. Now it is JCI certified, first cancer hospital to be JCI certified. It is not just a proton center, it is a cancer center as well. So we have facilities for surgery, radiation, and other therapies. And this is one of the rooms where the proton therapy is actually delivered. We call as GTR, which is gantry, because most of the proton rooms in the world are not fully rotating gantries. And fortunately, the recent ones, the more modern ones, all have been rotating gantries. In fact, when I visited as part of training in few centers in North America and Japan, most of them are either fixed or they rotate only in a particular arc, not the entire 360 degrees. Another unique and shocking thing which I noticed when I visited these centers was there were very few centers where image guidance was available. So you are transported back to era when you didn't have image guidance, and you invariably used to give larger margins, and because you were treating bit blind and you put in fiducials and doing things which are a bit old. Fortunately, the newer proton therapy centers like ours has all the paraphernalia which a modern linear accelerator has. It has got the image guidance in the form of a cone beam CT and a KV X-ray. So you have a choice of doing whatever imaging you want on a particular day. In fact, in Proton, we commonly use more than once imaging per patient per day. That means we may repeat a cone beam CT twice sometimes. We may use KV images maybe more often sometimes. So invariably we see that these image guidance are all required, and we have this available at our center, fortunately. Apart from this, we have other paraphernalia, typically like surface guidance and robotic 6D couch and so on and so forth, and gating, respiratory gating, and all those things. So for absolute newbies, protons, obviously the biggest benefit is that they stop. And they stop after a particular range. We call it as a range. That after it travels through in a particular medium, in the typical medium which is used to measure all the proton data is water. So it is called water equivalent thickness. So protons, and as you know, majority of the body is constituted by water, and protons, after a particular distance, after they travel particular distance in a medium, it deposits its entire energy within a few millimeter, and that is what we call as Bragg peak. And when we have this Bragg peak, the beautiful thing is the absence of exit dose. And why is it important in children? Because in children where the tumor to the normal body ratio is much larger because of the smaller diameter, smaller denominator, you have much larger tumor to body volume ratios. And because of that, it is even more important in children to spare normal structures. And with a 4 centimeter tumor lying in say a pelvic location, you would end up treating much larger normal body compared to an adult who may have the same size tumor in the same location. So, and that is the reason why more conformal techniques have got a bigger role in pediatrics. And typically in brain, in wherever the location is, irrespective of location, you see a dramatic difference between proton and photon distribution, especially in the context of a child where you would want to limit the doses as much as possible. Apart from this, there is also called the biological effect. That slide is not here, but the fact remains that the radiobiological equivalents, we consider them to be 10% higher than the conventional X-rays. Although to generalize it, it is fine, the 10% higher RBE, but in reality, the RBE itself ranges from about 5% to nearly 70% higher than X-rays. So in different locations of the Bragg peak. And to make it simpler, to make it easier, the consensus for RBE is just to use 10% higher than X-rays. So we also have something called pencil beam scanning proton therapy. Proton therapy also has evolved a lot in the last 20, 30 years. 1990 was the first time it was brought in a hospital. It was initially limited to physics laboratories. But when it started coming to hospitals in 90s, in the first hospital, these hospitals were not so well equipped in terms of other infrastructure, but you see that they had protons and very few limited sites and limited number of patients used to be treated. So they were not really high throughput, high efficient systems. Not only that, they were called something called passive scattering. And in the want of time, let me let me give you an analogy that the passive scattering proton therapy is something very, very similar to something like a telecobalt of proton therapy, because of course, there are many benefits of passive scattering, but you see that the conformality is very, very poor. The entry dose is significantly high. The skin dose is significantly high. You need to give larger margins. You have low throughput, low efficient systems. And because the systems are large, you cannot fit in the image guidance systems in addition to those passive scattering systems, which enable very limited sites to be treated. And there are a lot of limitations in terms of efficiency and throughput as well. But cut to pencil beam scanning proton therapy, which is like modern IMRT, where you deliver these Bragg peaks in specific points. And we do that and we scan the entire tumor point by point or spot by spot, layer by layer, and we do that for the entire tumor. And even in pencil beam scanning, which has been there since probably in more centers since 2010. I mean, it was there even before in PSI Zurich, but since 2010 it has been more commonly available. Even since 2010, there is a lot of evolution which has taken place even in pencil beam scanning, because the spot size was larger, so you had a larger penumbra compared to what we are currently using, the spot size of about 3 millimeters. Of course, it's not about how the option of what I want to use it. The spot size depends on many factors, but it is primarily it is kind of fine-tuned by the engineering system, how good the systems are currently. So with the current tuning, we have the spot size, which is at the highest depth, it is 3 millimeters. So 3 millimeter spot size is supposed to be the best you can achieve as far as pencil beam scanning is concerned. Of course, the spot size varies by the energy, the depth, and the spot size also would vary based on any other devices which you use to change the beam. And we also have, as I mentioned, cone beam CT, and also the type 3 algorithms, which are we commonly use, Monte Carlo and all those algorithms which take into account the lateral electron beam transport, which were not used in proton therapy for a long period of time. In fact, even when I was visiting some hospitals for training, those hospitals were still using type 2 algorithms, which are slightly primitive when it comes to compared to, let's say, modern IMRT is concerned. So fortunately, we have something called Monte Carlo algorithms, which are just similar to what the photon world we are familiar with. And these type 3 algorithms also have made a significant contribution as far as proton therapy is concerned. So when you hear about proton therapy in the literature, what they are based on, majority, because really pencil beam scanning, image guidance, smaller margins, smaller spot sizes have been available since last 4 or 5 years. So most of the literature you have heard, or I have heard, or you have read, are in the era where passive scattering proton therapy is used, where there is higher neutron scatter. Because of passive scattering proton therapy, they were inefficient systems, and because they were inefficient, they used to take a lot of time. And children, there's a struggle to treat them with this kind of technology in these systems. Without image guidance, so consequentially larger margins. The algorithms I have mentioned, they are primitive type 2 algorithms, even type 1 algorithms as well. There was no motion management system, no robust motion management system. So there were any tumor which moves, proton therapy was a strict no. But currently, what you see, and hopefully you will see this in the next decade or so, you will see modern spot scanning proton therapy. You would see insignificant neutron production, even less than some of the modern linear accelerators. These are efficient systems. Well, they are very, very efficient compared to passive scattering, not as efficient as VMAT and RapidArc, where you could treat nowadays. On Halcyon, you would treat about 200 patients. We have heard in a place in Gujarat where they have treated more than 200 patients in a day. But proton therapy is not reached that far in terms of efficiency, but still reasonably efficient now compared to the erstwhile systems. We are using same margin recipe which normally you would use in IMRT or typical image guided radiation therapy. As I mentioned, Monte Carlo algorithms and now motion management and surface guidance are now currently available, and there are ways and means to overcome some of the challenges, most of the challenges of the older generation proton therapy. So people have always asked me, is it a hope or a hype, and so on and so forth. And we, as radiation oncologists, we have always seen that the technology has really helped. We have been hearing the same question when it came to telecobalt versus LINAC. When I joined MD, there was some debates regarding whether we should say goodbye to telecobalt. Then came a lot of debates, and I used to attend and in fact even speak on some of them when I was in TMH, 3D CRT versus IMRT. Then came IGRT, is it really required? There was no much controversy, thankfully. But SBRT then came, and then it was, of course, it is the physics has enabled this, the biological modification of fractionation, what we use, hypofractionation, maybe new way of dealing with things, and again a hope or hype. And now proton therapy, again we are fighting with naysayers as far as is it really hope or hype. And this is the slide which I commonly show. Very respected radiation oncologist from United Kingdom, I'm sure most of you have heard his name, Mike Brada. And he has been a major, big opinion leader in radiation oncology, and rightfully he had an opinion whether SABR and NSCLC is probably getting near the end. This was in as much as late as 2015, which is just not far away, 5 years ago. And we know now that SABR is actually indeed the standard of care in 2017 for many sites in lung cancers, for example. So when it comes to standard of care, we want most conformal technique especially for children. We want to spare the organs at risk to the best extent possible. We want tight margins. We want faster, efficient delivery. We also want it to be accessible. We also want it to be affordable. The cost has to be of an affordable range to majority of, say, Indians in India. And obviously, we want to have a low dose spillage and integral dose to ensure that whatever models show us the second cancer risk is minimized. So is Proton standard of care for pediatrics? Probably not. Still, because of accessibility and cost, which remain a major challenge for proton therapy. And I'm sure as the footprint of protons comes down, with more proton therapy centers available, the access will increase. With more number and better technologies, the cost will come down, and hopefully in the future, proton therapy could potentially be a standard of care, especially in many malignancies. So as far as pediatric proton therapy is concerned, this was from a Stockholm pediatric, but this is nothing related to Stockholm. The meeting was conducted in Sweden, and some of the leading pediatric radiation and medical oncologists have been part of this group meeting. And you can see Dr. Laskar's name also in this. We all know him as a leading radiation oncologist in pediatric field probably in the world, and no wonder we see his name here. And what they were asked is, a young child with a curable tumor requiring delivery of moderate to high focal radiation dose in proximity to critical structure. This is what this group recommended proton should be. Then there are people from Canada, there are people from UK, there are people from all over the world who have recommended this. And they have seen that they have kind of recommended it for almost all pediatric malignancies, be it low-grade glioma, optic pathways, germ cell tumors, medulloblastomas, intracranial, extracranial tumors. All of them have been uniformly recommended proton therapy if there is a child, and except for maybe high-grade gliomas. And no wonder ASTRO also in its model policies, of course, they cannot give a guideline as a standard because again, as I said, accessibility and cost are concerns, but they have put pediatrics in group 1 tumors where on the basis of medical necessity requirements and published clinical data, the disease sites that frequently support the use of PVT. And they have included primary or benign solid tumors in children treated with curative intent. And you can see here, including they have in fact mentioned occasional palliative treatments as well in certain situations. And you see that ocular tumors, skull-based tumors, spinal tumors, and brain tumors. And another important which I would like to mention is a patient with familial or genetic syndromes such as NF1 or retinoblastoma. Of course, in these syndromes, one would like to avoid radiation as much as possible, and one must avoid radiation as much as possible. But if there is no option, there is no alternative that you must give radiation, then definitely you must consider proton therapy, irrespective of the location. And patients requiring re-radiation, of course, even in adults, it makes sense to opt for proton therapy in this group of patients. So let me summarize some of the benefits of proton therapy for the audience. Proton therapy delivers less radiation to normal tissues compared to any photon techniques. I don't think any of you would contradict me in this particular statement. And in majority of the situations, it is indeed true. And And we all know that radiation related late effect is a reality. And we don't see late effects in tissues which do not receive radiation. I'm sure you agree on that. And you see only radiation related late effects in tissues which are irradiated. And we see hearing loss. So when a child comes to the clinic, we would tell the child's parents regarding hearing loss, impaired cognition, impaired academic performance, and endocrine dysfunction, growth abnormalities. Depending on the area you're including in your target, you would also say organ dysfunction, say for example, cardiovascular issues, infertility, vasculopathy, if you're treating brainstem necrosis, optic pathway dysfunction, social, psychological, impaired quality of life, and second malignant neoplasms. And all these, maybe except for second malignant neoplasm, you have a typical dose thresholds for each of these late effects. That means you deliver a particular dose to a particular organ at risk, you have a higher propensity for a late effect. And this is, as I said, most of them are dose dependent. So you give a higher dose, there's a higher chance. And you see from the St. Jude Life study, this is the sibling curve and this is the actual patient treatment curve. There are late effects, which is a reality. And as radiation oncologists, we cannot deny the fact that radiation also contributes significantly. Of course, we must also remember that chemotherapy contributes to it, surgery contributes to it. The psychosocial impact is always there because of the disease and the child getting more or less attention. But the fact remains that the radiation also does contribute to late effects. And this is the result from the St. Jude Life study. And you see that there are a lot of late effects in leukemias where radiation is actually very minimally used. And even then you see in ALL/AM a lot of late effects. But you see late effects in Hodgkin's as well, non-Hodgkin, CNS tumors, bone tumors, soft tissue, Wilms, neuroblastomas, retinoblastomas, and germ cell. And all these, including all these late effects, are quite common, and these always must be remembered. So let me, in the context of what we normally deliver these treatments and what late effects some of us contribute to, unfortunately, what could be the additional value of protons? And you see that because of these is a very often quoted study from St. Jude's, Tom Merchant's group, showing that the neurocognitive decline is a significant factor. The IQ decline as the child ages is significantly there in patients who have received photons versus protons. And this is based on a number of patients, but this is actually a modeling study. You may not agree with this model, but this is based on actual data. Nevertheless, there is now data to show that with proton, the intellectual outcomes are superior, even in patients receiving craniospinal radiation, where you irradiate the entire brain with protons, entire brain with photons, and despite that, there is a significant difference in intellectual outcomes. This is medulloblastoma is just a model. We know now that it is not because of any modality. It is actually the dose dependency, and we now till now we have only found out that hippocampus is one of those structures which could impact on neurocognitive outcomes. But there could be more. We might not know. So entire supratentorial brain, according to me, some portion of it at least, is at a risk. When you irradiate them to a higher dose, there could be higher neurocognitive decline. And this has been shown by a number of other studies, which also showed that neurocognitive performance is dependent on age and socioeconomic status. That is also fine. Hydrocephalus requiring shunt, requirement of craniospinal radiation, presence of posterior fossa syndrome. These are all impacting, but there is also impact on what modality is used to treat children. So there is also a lot of data on preservation of endocrine dysfunction. Again, this is dose dependent. You deliver a lesser dose to pituitary hypothalamic axis, you have a lesser chance. So you may argue that if there is a tumor very close to pituitary hypothalamic axis, we must include that in the target. Then there would be no difference between proton and photon. But in temporal lobe targets, in thalamic targets, in posterior fossa targets, you could clearly see that there is significant benefit in terms of the propensity to cause endocrine dysfunction, in terms of hypothyroidism, sex hormone deficiencies, any hormone replacement, and so on and so forth. This was from the Bree Eaton from Harvard. Reduced probability of secondary neoplasm. Again, people say it is a model. Is there a real data? Yes, there is a real data, and now we know the reason as well. That this is one of the data from, again, the Boston group, where they have actually shown this is from the passive scattering era. And in the passive scattering era, you see that there is a more of a neutron contamination compared to IMRT. And despite a higher neutron contamination, the risk of second cancers were lower in photons. And this is expected to be lower, slightly lower, when it comes to proton, which is modern pencil beam scanning, because there is no neutron contamination. And hopefully this will be able to reduce the second cancers even further. I mean, if somebody wants to know, I have summarized this in a publication which was published 2 years ago, and a lot of models we have discussed in how you would determine the risk of second malignancies. Is it low dose? Is it intermediate dose? Is it age? Is it inherent risk factors? And many things. One could refer this to this publication where you could get more details. There is also something called vasculopathy. There is a significant amount of vasculopathy when you irradiate brain, normal suprarenal brain. And this is also significantly reduced in protons, because you see that the vessels, you don't irradiate them at all to any dose. And these could have an impact, because the incidence of vasculopathy is nearly 10%. And we know that there is risk of cerebrovascular accidents and a higher risk of vascular related events in children who receive radiation, not just to brain, but to head and neck region, even thorax. And there is definitely a reduction in the rate of vasculopathy in these children because of proton therapy. Another big advantage is reduced organ dysfunction. It is a nightmare for us to tell parents that the child is going to be infertile. Obviously, whatever pelvic tumors I have treated with protons, just like what I used to do with photons, we do a lot of transpositions. We do other kind of modalities like oocyte collection, preservation, and all those things. But having said that, if you are able to deliver protons without causing significant doses to the uterus, to the ovaries, there is a definite reduction in the chances of infertility in the future. And similarly, there are cardiovascular, renal, hepatic dysfunction which can happen typically in Wilms tumor, where we irradiate to a very low dose, 20-24 gray. And you have seen the late effects of, and Wilms tumor does not require a lot of chemotherapy. I mean, there are, of course, high risk Wilms tumors where they receive a lot of treatments. But in certain group of Wilms tumors, you have limited 2 or 3 drug regimen. You give only 20-21 gray, even less than that sometimes. And then you still see a large burden of late effects in these children, because it causes nephropathy, hepatic issues, cardiovascular issues are very common in several malignancies, in thoracic, in lymphomas and other tumors as well. So all this probability also are dose dependent, and if you are able to deliver less dose with protons, these could be a preferred modality in these group of children. It is not all hunky-dory with protons. There are certain concerns with proton therapy. The most important are There are a lot of uncertainties as radiation oncologists. I'm sure most of the audience today are radiation oncologists, so I can be clear and frank with you that there are multiple proton-specific uncertainties which are unique to protons. Some are unique, some are standard. So the biggest variation remains contouring, by the way, not proton or not photons. So target delineation, imaging, margins remain the largest uncertainty, which are not proton specific. But proton specific are the distal and RB effects, which is the biological effects, the CT artifacts. The first thing which I do is check a scan, see is there any metal, is there any clips, is there any mesh, is there any metal is there in the volume or region of interest, is extremely important for me to determine whether or not I would recommend proton for a particular patient. So, but there are now ways and means to overcome these uncertainties. The standard physical uncertainties can be overcome by something called robust optimization, which takes into account both the setup uncertainties as well as the range uncertainties. Several physical uncertainties can be overcome by Monte Carlo algorithms. The radiobiological uncertainties can be overcome with something called LET-based evaluation and optimization. We do not yet have RBE-based optimization because, you know, these RBE, and when you calculate your NTCP, you have, you know, those factors which you have to put into those formulas, and we do not know factors of heart and liver would be different, lung would be different, we don't know, and we commonly generalize them. So we do not yet have RBE-based optimization, but we have something which is more reliable parameter, which can be easily measured, which is a physical parameter, which is LET here. So LET is used to evaluate and optimize the target volumes. Motion to a certain level, interplay effect is an issue. It brings in a little bit of uncertainty. Again, you use specific planning beams, you use interplay effect estimation, you use rescanning techniques, gating, breath hold, tracking to make sure that these uncertainties are minimized. Still, I would say tumors which are moving very erratically, much more than 1.5 centimeters, not suitable for breath hold, is a patient probably not suitable for proton therapy. But as I said, majority, I'm yet to see a patient who is based on motion I have rejected so far. Ongoing response, majority of the patients have ongoing response, so it keeps changing, that it is much more sensitive to this ongoing response than photons, and hence you would definitely require something called adaptive treatment, which we normally do in photons, but much less often. So we do adaptive treatment much more common, and out of first 120 patients, 47 patients required adaptive treatment at our center. Now we have treated 200. So out of 200, now around close to 65, 66 patients receive. So almost 33% of patients receive adaptive treatments. Often I've been asked this question regarding brainstem necrosis. Is it a factor anymore? It was a factor, in about 303 patients, 11 cases of symptomatic brainstem injury was found. And there was a lot of investigation. Is protons causing brainstem necrosis? Not really. It is poor dosimetry is causing brainstem necrosis. So when you have delivering much higher doses, especially in the context of an uncertainty, physical and biological uncertainty, you would end up having higher toxicity. So with the recent series we have seen, last 5-6 years, we have seen that in proton world, you see very less brainstem necrosis, comparable or even lesser than what you would see with photons. So of course, there are some specific dose constraints which we follow to avoid brainstem necrosis, slightly more stringent than photons, to build in that biological component of uncertainty. Otherwise, it is just the same as far as dosimetry is concerned. So we have treated I've treated 47 patients at our center. both CNS and non-CNS tumors. Of course, it is with some of patient treatments have been with my colleague Dr. Jalali, who also treats brain tumors. So we would show some of, I would show some of the snippets. So in brain tumors, of course, these were shared between me and my colleague, but we've treated about ependymomas, gliomas, craniopharyngiomas, medulloblastomas, germ cell tumors, pineoblastoma. Again, a large chunk of these actually received craniospinal radiation, 13 of these 27. So nearly 50% of brain tumors have received craniospinal. We also treated a significant chunk of head and neck rhabdomyosarcomas, Ewing's, osteosarcomas, abdominal tumors, thoracic tumors, skull base, pelvis, and all these were the histologies as far as the non-CNS are concerned. And as I said, till March 2020, of course, we have added about 10 to 12 patients beyond March, but we have treated nearly 47 children with proton therapy. Very gratifying results so far. This was one of the vaginal germ cell tumor we have treated. Post few lines of chemotherapy, you see the beautiful sparing of the superficial structures, which can actually significantly change how the child would be after at the end of the treatment. This is one of the pelvic rhabdomyosarcomas, bladder prostate rhabdomyosarcoma in a 4-year-old child. We treated with relatively simpler portals, posterior obliques and laterals, and you could see that we could spare beautifully the femoral epiphysis and metaphysis of the bone marrow. All these structures received significantly low doses compared to a comparative photon plans. Nasopharyngeal cancers, I think this is a very, very attractive site for tumors, especially as, I don't know whether some of you know or not, the recent COG trial has shown that 62 gray is enough in those children who achieve either a complete or a good partial response with neoadjuvant chemotherapy. You don't need to give 70 gray. This is very important. So if you are treating a young child with pediatric nasopharyngeal cancers, majority of them are EBV positive. Majority, probably 99% of them are EBV positive, and for them you don't need to give 70 gray. And we have seen in children, we have treated about 3 of them so far, and we have seen very, very gratifying results. No need for tube feeding and very little mucositis, which we have observed in these children. Medulloblastoma, of course, any child who requires CSI, maybe a recurrent ependymoma or a medulloblastoma, these are probably the biggest benefactors of proton therapy. You see, I mean, the dose DVH and the dosimetry is simply incomparable compared to IMRT as far as especially the low dose volumes are concerned. And in an adult patient, post-pubertal male, you can actually spare the vertebral body as well significantly. So that is a very, very useful. And of course, you see a lot of esophagitis also in medulloblastoma, but with slight tweaking in proton therapy plans, we have been able to deliver without any esophagitis in these children, especially when you treat them with 35 gray and when you're giving a high risk medulloblastoma, group 3 tumor where you're giving a concurrent carboplatin every day, you would definitely see a lot of neutropenias and esophagitis, which can be completely avoided with proton therapy. As I said, ependymoma and RMS are probably the most common indications which we have treated at our center, and both upfront ependymomas and recurrent ependymomas we have treated, both with CSI as well as focal RT. This is one of them which extends up to the supratentorial region. You see that large target, and we could spare a good amount of supratentorial brain to almost no doses of radiation. Craniopharyngioma also remains a very good indication for proton therapy. You see that the hippocampus bilaterally is beautifully spared, and the dose which you can achieve, mean dose, is significantly lower compared to the typical photon plan. This is one of the skull-based tumors which we have treated in a 3.5-year-old child from Delhi. Large, bulky clival chordoma extending into the oropharyngeal isthmus, and large, bulky lesion. In fact, the child presented with a little bit of odynophagia and dysphagia, and we did a little bit of debulking, whatever we can, and then we irradiated. Again, you can see that the brain stem is actually limited to a small area. A lot of it is actually tumor. And with such large target as well, we have an excellent pediatric sedation team. Because these proton therapy typically takes about 35 to 40 minutes of treatment. So you need a very dedicated proton sedation anesthetists who are available with us. And we typically use, for chordoma, we treat equivalent of 76 gray whenever possible. The dosimetry allows, of course. Or 74 gray if dosimetry does not allow. And this is what we have used in this child. We have given 74 gray equivalent to this child, to a very small, young 3.5-year-old child. And I don't have those slides, but the child is doing very well with almost near complete response. We never see a complete response with chordomas. Almost invariably, they are stable disease. But this child, special case, because it's a dedifferentiated chordomas, and we actually have seen after end of almost 9 or 12 months, near complete response with a lot of scarring, of course, because we gave more than 70 gray. Low-grade gliomas, we have treated a significant chunk. Pilocytics, majority of them are pilocytic astrocytomas. We've treated both posterior fossa and supratentorial ones. Pineal region, in fact, I have treated 2 pineal region. Dr. Jalali also has treated 1 pineal region tumor recently. And we see that pineal region tumors, again, a very good indication for proton therapy, where you would spare a good amount of temporal lobes and supratentorial brain and hippocampus. This was the dose distribution you see. So many things we have learned. We have learned what is the best proton technique. Is it single field optimization, something called multi-field optimization? SFO is very similar to a forward planning IMRT. Multi-field optimization is very complex inverse planning IMRT. And you see that there are differences as you evolve, and you understand which are the targets and which are the locations where you should use SFO. SFO is the best modality because it brings in much lesser uncertainty when it comes to target motion is concerned. And we have seen that, of course, there is something, when the target is very superficial, we use something called range shifters to bring something like a bolus in photons. And we now know by experience that what thickness of range shifter must be used for what targets, so as to see that the best dose distribution is achieved. This was one of the orbital rhabdomyosarcomas which I have treated, was lateral in location, and we did an MR. I think the video is not working. Typically, how it. So we took a video and we saw optic nerve, how it was moving, and based on that, on MR scintigraphy, we try to immobilize the child's gaze in one particular direction, and then we could treat the tumor without giving much dose to optic nerve. We have seen some setbacks. 4 of the children, 4 out of 47 children have actually progressed. One was, of course, we treat very challenging tumors. We treated one metastatic neuroblastoma with an isolated CNS metastasis where we had to give CSI because the child failed systemically. There was one germ cell tumor which I showed, vaginal germ cell tumor, which failed after 3 lines. Normally in non-seminomatous germ cell tumor, extragonadal germ cell tumor, we do not use radiation because this child had already received 3 lines of chemotherapy. The child was progressing, but only locally progressing. That is why, of course, the child underwent almost 4 surgeries, very young child, to vagina. Then hence we irradiated, and again, there was no benefit. Of course, as I mentioned, there are a lot of challenging patients we see sometimes because they do come to Proton Center when things are very, very desperate. So some of them have recurred. This is one of the normal cases which has recurred, which is a pelvic prostate rhabdomyosarcoma. There was radiologically complete response once we finished the treatment, continued chemotherapy till 42 weeks, and then everything was fine. Then we realized that there was non-FDG avid bladder base thickening. This is typically a pseudo progression, normally documented for pelvic rhabdomyosarcomas. There is recently a publication saying that beware of these pelvic pseudo progression, don't do biopsies multiple times. We said the same. Fortunately, the pediatric urologist didn't listen to us and kept on doing biopsies. But unfortunately, in one of those biopsies, it actually turned out to be malignant rhabdomyosarcoma. So it was progression indeed. And the child, of course, underwent salvage cystectomy. His child is doing very well now. But these were some of our recurrences as far as the 47 patient data is concerned. This is, as of yesterday, this was accepted with minor revisions. So you will soon see this manuscript in publication in Journal of Clinical Oncology, Global Oncology. So where will the answer come from regarding proton therapy for pediatrics? In rapidly evolving technologies, it is extremely challenging to perform randomized control trials. And as such, there are randomized trials in protons. There are many, but there are more than 2,000 clinical trials going on, but none in pediatrics. There are pediatric randomized trials going on, but not addressing a proton question per se. So because there are no RCTs, we will have to rely on prospective data sets, retrospective outcomes, and dosimetric studies to answer this question and tell this to the parents. This was an update from Pediatric Proton Consortium Registry. This is an extensive multi-institutional registry, which we hopefully will be part of after we finish 3 years. And these are some of the registry data which are available. And they also shown very, very encouraging outcomes with both CNS and non-CNS tumors as far as the registry data goes. So the predicting future is not easy. Especially in context of rapidly evolving technologies, people believe that someday they would be able to see the person on a monitor while they are talking. But I mean, the creativity was there very much, but you know, we have moved much better than what this wildest imagination in probably 70s or 80s was concerned. And in UC 2000, it is something else. And whatever wildest imagination we think of now, what will happen after 20 years, may be wildly or grossly off target. So I would like to thank all my colleagues for this experience so far at Proton Center, my colleagues at Radiation Oncology Department. There's something called HOPE team, which is our pediatric medical oncology team. And of course, the medical physics, the therapy, the pediatric sedation teams, which is very, very important. And we are soon, again, that has been sent for publication, is under review, and what pediatric different changes we have made to our pediatric sedation to ensure safe delivery of protons in this group of patients. We are going to publish very soon. Thank you very much, and thank you, Dodal, for having me and